to introduce our speaker today. Brooke, she just told me how to spell her last name and I just drew a blank.
Vergales.
Sorry. She's an associate professor of pediatrics at the University of Virginia. She graduated from Tulane University of Medicine and completed her pediatric residency at the Rainbow Babies and Children's Hospital. She then moved to Virginia for her fellowship in neonatology medicine at the University of Virginia and joined the faculty in 2012. Dr. Vergales also serves as the program director for the neonatal fellowship at UVA. So welcome, and we will turn it over to you.
Mute, and I can share my screen, is that correct?
Yes, you should be able to.
Okay. Okay, what do you guys see?
We see it.
You see it?
Yes, ma'am.
Okay. All right. So thank you for that introduction, and to the VNPC committee for inviting me today to give this webinar. I got interested in this topic because I've been working with a multidisciplinary group here looking at more at closing PDAs and atrial level shunts in the cath lab. And Joseph Corey reached out to me to kind of present on the topic with that interest. So today I'm going to talk about the PDA then and now. I have no disclosures with regard to the PDA. So my objectives today are to understand the history of the PDA in neonatology, review the pathophysiology of the PDA, and then the majority of the talk will be spent discussing the different treatment options that have been used over the year. And finally, by the end, you'll be able to compare the different treatment options and how they compare to each other. So I'll start with a little history, and I get this from, I don't know if he's on here today, but Josh Attridge was one of my mentors during fellowship, and he had a real interest in the PDA and always really liked to talk about the history. So Claudius Galen is usually given credit as being the first to offer a clear description of the foramen ovale and its valve and the ductus arteriosus in fetal cadavers. He said, since the fetal lungs cannot move, as do the perfected lungs of the adults, nature has anastomosed the pulmonary artery with the aorta and the left and right atria. I would say this is pretty accurate for around 200 CE. So nothing else much was thought about the PDA or the ductus arteriosus for 1500 years, when Leonardo Bartali was hailed to have discovered the ductus arteriosus with his drawing in Opera Omnia, although this was not published till 1660. In this book, the ductus was referred to as the ductus Bartali. And actually, as late as the early 1900s, it was still referred to as the ductus Bartali in some textbooks. So if you look at the last 200 years, how did we kind of get to where we are now? So in 1816, the stethoscope was invented by Rene Laennec, allowing for the discovery of heart murmurs and sounds. About 75 years later, in 1898, Dr. Gibbons describes the PDA murmur for the first time as a systolic murmur that is continued beyond the second heart sound. And then in about 14 years later, in 1938, Dr. Robert Gross was credited with performing the first PDA ligation on August 26. He ligated the PDA of a 7-year-old girl who was suffering from heart failure. This is not a neonate I'm discussing at this time, but it is the first of surgical ligations. I think it's a really fascinating story to tell is that Dr. Robert Gross was actually a resident at the time under William Ladd at Boston Children's Hospital. And Dr. Ladd had specifically prohibited Dr. Gross from attempting the PDA ligation. Dr. Gross felt very strongly that this would help the little girl and waited for his attending physician to go on vacation. He then obtained permission from the acting surgeon-in-chief and operated on the 7-year-old girl. Dr. Ladd, when he returned, fired Dr. Gross, but Dr. Gross was so popular from his success that Dr. Ladd was forced to rehire him. So I don't know how well that would go over these days, but I think it's a really interesting story. In the 1940s, we actually have the introduction of cardiac cath, which allows for more accurate correlation between cardiac murmurs and their precise anatomic locations. And then in 1958 is when we actually start talking about the PDA in newborns for the first time. And this is the first paper it was really described in by Dr. Bernard, and he describes the PDA murmur in a newborn baby. In the 70s and 80s, you start to see the development of the echo machine, allowing for a non-invasive way to precisely diagnose cardiac defects. And then if you jump all the way to 2019, the US has an FDA-approved Amplitaz or Piccolo device that can be used by interventional cardiologists to occlude the PDA in the tiniest premature infants via a catheter approach. So we say that the first murmur and the first talk of it was in 1953. So 1950s is actually the beginning of modern neonatology. This is when you start seeing assisted ventilation of newborns becoming a routine part of neonatal care. Along with this, you start to recognize the common NICU conditions that occur when premature infants survive beyond the first week, such as neck, intracranial hemorrhage, sepsis, failure to thrive, bronchopulmonary dysplasia, and retinopathy of prematurity. With these morbidities comes a recognition of the PDA. And the question becomes, what is the contribution to the PDA to these morbidities? So in the 1950s, these questions arrive. The first is, what is the role of a significant PDA in causing these morbidities? Number two is, how do you assess a hemodynamically significant PDA? Should you treat the PDA? And if you actually treat and cure the PDA, will it improve the outcomes? I want you to remember these questions. They're going to come back. And I want you to remember that these were posed in 1950. So let's start with the basics and talking about the pathophysiology of the PDA before we continue on to management options. In the developing fetus, blood flows from the right side of the heart to bypass the non-functioning lungs to the systemic circulation via the ductus arteriosus, which is there. The ductus arteriosus connects the pulmonary artery trunk to the descending aorta, bypassing the high resistance pulmonary bed. During fetal life, the ductus remains open as a result of prostaglandins, most notably prostaglandin E2, which is produced by the ductus arteriosus itself and the placenta. After delivery, the removal of the low resistance placenta causes an increase in systemic arterial pressure. And simultaneously, the first breath allows for lung inflation and oxygenation, allowing for a decrease in pulmonary vascular resistance, leading to ductal flow becoming left to right instead of right to left. Eventually, the ductus will close as blood flow becomes less and less. In the term infant, so we're talking about kids born at term, the ductus generally closes over hours to days because of loss of the prostaglandins from the placenta, increased breakdown of prostaglandins in the lungs, and decreased number of prostaglandin receptors. With the increased oxygen tension, we see vasoconstriction within the ductus lumen, producing functional closure. This hypoxic zone induces vascular endothelial growth factor, leading to remodeling, vessel occlusion, and eventual anatomic closure of the ductus arteriosus. So functional closure usually occurs within 72 hours, and then anatomic closure usually occurs within 1 week. Things are a little different for the preterm infant. At 1 week of age, the PDA is still present in 65% of neonates born 25 to 28 weeks gestation. And it's still present in 84% of infants born less than or equal to 24 weeks gestation. According to one study, 29% of neonates born 23 to 26 weeks gestation had not achieved spontaneous closure of their ductus arteriosus at 36 weeks post-menstrual age. So why is this? So the preterm infant has increased sensitivity to prostaglandins and a higher expression of prostaglandin receptors in the ductus walls. There is a higher level of circulating PGE2 caused by the reduced catabolism in the premature lungs. The third reason is that there's fewer oxygen sensing ion channels in the ductus tissue in premature babies. So therefore they do not have this functional and anatomic closure. They also have a higher sensitivity to vasodilators such as nitric oxide, which allows the vessel to remain dilated. And finally, even if functional ductal closure does occur, true anatomic closure may not take place due to incomplete development of the vasa vasorum, which I'll show you in a second, and inability to potentiate that hypoxic zone. This is why that ductus in the preterm neonate can actually reopen. So you may do an echo at day 3, 4, 5 and don't see the ductus, and then the kid gets sick, or you give a huge bolus and the ductus is open at day 7 to 10. This slide pretty much summarizes a previous slide in a picture. The main pathways that maintain ductal patency in fetal life is shown in blue. They include nitric oxide sensitivity and PGE sensitivity. As you can see, as gestation goes on, sensitivities to nitric oxide and PGE both steadily decline throughout the gestation. The receptors that you can see at the bottom in the diagram, the blue receptors are much higher in the preterm ductus than they are in the term ductus. The main pathways that promote ductus arteriosus closure are in red. They include PaO2 and pulmonary blood flow, which you can see increase dramatically postpartum. Intrinsic tone of the ductus, ion expression channel, prostaglandin diesterase, which breaks down prostaglandins. And as you can see, all of these increase throughout gestation, and the relative abundance of the red receptors on the ductus are higher near term. You can see that down there. The vasovasorum, which are the little pink lines that you see in the ductus media, are there to create a hypoxic zone. As you can see, the preterm ductus has a much larger lumen compared to the term and post-term ductus, and minimal ductus vasorum, leading to difficulty with anatomic closure of the PDA. So this slide is a summary of how the PDA can affect the preterm infant and the causal relationship to neonatal morbidities. So you get persistent left to right shunting, allowing for increased blood flow through the pulmonary vascular bed, leading to pulmonary overcirculation and consequently systemic hypoperfusion. This is referred to as ductal steal. The pulmonary overcirculation can lead to pulmonary edema and hemorrhage, thus exacerbating respiratory distress syndrome and leading to bronchopulmonary dysplasia and potentially pulmonary hypertension. Decreased systemic blood flow can lead to hypoperfusion of the kidneys and intestines, leading to potential AKI and neck, respectively. And then the increase in pulse pressure causes the PDA causes fluctuation in cerebral blood flow, which could lead to IVH and PVL. So now back to these questions that were posed in the 1950s. And now we're going to go on to talk about, should you treat the PDA and what should you treat the PDA with? So this is one of the very first randomized control trials testing the benefits of early surgical ligation of the PDA that was completed in 1976. 42 infants with respiratory distress syndrome were between 550 grams and 2,000 grams were randomized to medical treatment of the PDA versus surgical ligation of the PDA. Those who were unable to wean from the ventilator in the medical treatment group could have the ligation at a later time. In this trial, they found no difference in late survival between the two groups. They did note that with this trial, there were minimal operative risks associated with the procedure. So there's really only been 3 randomized controlled trials that have assessed the impact of this treatment in neonates. 2 trials performed the ligation after the baby was deemed to have a significant PDA, and they showed no improvement in mortality, BPD, or neck. 1 trial prophylactically ligated the PDA early, and they also showed no reduction in mortality, IVH, or ROP, but they did show that the rate of neck was reduced in those that had prophylactic PDA ligation. But they also showed that the proportion of infants who required supplemental oxygen at 36 weeks was increased in the babies that had the ligation. And when you consider surgical ligation, you need to consider the potential complications that are associated with that. The first is potential for severe left ventricular dysfunction leading to cardiopulmonary decompensation immediately postoperatively. I can say that I remember this very distinctly as a fellow when we were doing a lot of PDA ligations occurring. They do say that it does tend to improve if you do the procedure after 4 weeks of age. You also have the risk for a chylothorax, pneumothoraxes, and phrenic and recurrent laryngeal nerve damage. But yet, in the 1970s, there was an emerging consensus that surgical intervention was strongly indicated in preterm infants with a persistent PDA and respiratory insufficiency. And in 1976, we see the first publication exploring the use of indomethacin, an inhibitor of prostaglandin synthesis, as a treatment for PDA in premature infants who would have otherwise undergone surgical ligation for their PDA. This study occurred in 6 patients, and they reported in the paper that 24 hours after administration, they showed closure of the PDA with improvement in the symptoms attributed to the PDA. But they also reported the known side effect of reduced renal function in 2 out of the 6 patients. This study ultimately led to the National Collaborative Study on the PDA, which was published in 1983. You have to realize at the beginning that the ultimate goal of this study was closure of all the PDAs. There was no non-treatment arm. All 3 regimens mandated ductal closure by either indomethacin or ligation in the end. So in this trial, once the diagnosis of a PDA was made, the neonate was randomized to either usual medical therapy plus indomethacin or usual medical therapy plus placebo. Usual medical therapy included diuretics, fluid restriction, and possibly digoxin. If the neonate in the indomethacin arm did not have their PDA closed, they then underwent surgical ligation of their PDA. The placebo arm patients, if they did not have spontaneous closure of their PDA, were then randomized to receive either late indomethacin or surgical ligation of the PDA. And again, if the indomethacin arm did not result in PDA closure, they underwent surgical ligation of their PDA. And the conclusion of this seminal paper was that there was no difference in mortality or BPD between these 3 groups, that infants given indomethacin only after initial failure of medical therapy had lower incidence of bleeding than those who received indomethacin early, and that infants given indomethacin after initial failure of usual medical therapy had lower rates of pneumothorax or an ROP than those who received no indomethacin and only received surgical ligation. They concluded ultimately that indomethacin given after failure of medical therapy seemed to be the preferable approach for management of the symptomatic PDA. This seminal paper was followed by more than 40 randomized controlled trials, and probably more to date, of ibuprofen or indomethacin for preterm infants. And basically, the final conclusion of all of these studies is that indomethacin and ibuprofen are equally effective in reducing rates of PDA. Indomethacin is less likely to be effective after 10 to 14 days of age. Repeated courses may be effective in infants who do not respond to first or second courses of medication. And neither individual nor meta-analysis have shown significant improvement in long-term outcomes. You also need to consider the side effects associated with cyclooxygenase inhibitors, including reduced cerebral, mesenteric, and renal perfusion. Also, co-administration with glucocorticoids is associated with increased risk for bowel perforation, and ibuprofen can displace bilirubin, leading to hyperbilirubinemia. So what about paracetamol? So again, these all kind of started to be discussed as cyclooxygenase inhibitors in the late 70s, early 80s. And then it's not till 2013 that you start seeing the use of paracetamol or acetaminophen being used for the closure of PDA and neonates. So this adds yet another medication to our arsenal. So acetaminophen works by inhibiting prostaglandin synthesis by interfering with arachidonic acid metabolism via prostaglandin H2 synthase. Prostaglandin H2 synthetase is responsible for breaking down arachidonic acid from prostaglandin H to prostaglandin H2 in a stepwise fashion, leading to the precursors of prostaglandin production. So first, cyclooxygenase, or the COX site, oxidizes arachidonic acid to prostaglandin G2. Peroxidase, or the POX site, subsequently reduces prostaglandin G2 to prostaglandin H2. Cyclooxygenase activity is contingent on the generation of a radical cation by peroxidase. Peroxidase can work regardless of cyclooxygenase. So NSAIDs work by competing with arachidonic acid at the COX site, thus preventing the breakdown of arachidonic acid to prostaglandin G2. Acetaminophen competitively inhibits the POX site, thus not only preventing reduction of prostaglandin G2 to prostaglandin H2, but also limiting the electron transfer from POX to COX, thus also reducing the COX activity. Therefore, it would make sense that acetaminophen could be a good choice for potential PDA closure in neonates. So this is one of the original studies in 2013. It was a randomized, non-blinded, parallel controlled, and non-inferiority trial of 160 infants less than or equal to 34 weeks gestation with a PDA confirmed by echo. These infants were randomized to oral paracetamol or ibuprofen. The need for second course was determined by echo evaluation, and the main outcome of this study was the rate of ductal closure. The secondary outcome was the clinical side effects or complications. The whole goal of this study was to be a non-inferiority study. So the results of the study showed that the ductus arteriosus was closed in 81% of infants that received paracetamol and 79% of infants who received ibuprofen. So therefore, they were able to conclude that paracetamol treatment was not inferior to ibuprofen. They also showed that the incidence of hyperbilirubinemia and GI bleeding was significantly lower in the paracetamol group, with no significant difference in other clinical side effects or complications. So then when I looked at the Cochrane review, so again, we don't have, this really started to be talked about in 2013, so we don't have a lot of data yet. The Cochrane review published in 2020, looking at efficacy and safety of paracetamol when compared with placebo, no intervention, or COX inhibitors included 8 studies with 916 preterm infants. The conclusions of the Cochrane were that the success rate of paracetamol for PDA closure was higher than placebo or no intervention, but it was similar to that of ibuprofen or indomethacin. Paracetamol seems to have fewer adverse effects on the kidney and liver, and one study showed no difference in neurodevelopmental impairment, but we definitely need more studies to evaluate this in the future, as not many of the acetaminophen studies have looked at long-term outcomes. So overall, with acetaminophen seeming to be as effective and with less side effects, it makes a good addition to our PDA treatment options. To conclude the comparison of the treatment options, I'm going to go over the systematic review and meta-analysis published in JAMA in 2018 that compared placebo, indomethacin, ibuprofen, and acetaminophen for closure of the hemodynamically significant PDA. This study included 68 randomized control trials that included 4,802 infants. There were 14 variations of indomethacin, ibuprofen, or acetaminophen. The primary outcome was PDA closure within 1 week of administration of the first dose. The secondary outcomes were the need for repeat pharmacotherapy or the need for a surgical PDA closure. This is a set of the adverse events that they were looking through the meta-analysis. They included neonatal mortality, NEC, spontaneous intestinal perforation, gastrointestinal bleeding, time to full enteral feedings, BPD, IVH, severe IVH, PVL, and neurodevelopmental disability. And they also looked at oliguria. So they had these network plots that they used to measure outcomes. Each node indicates a treatment modality. These are the nodes. And each line connecting 2 nodes indicates a direct comparison between 2 modalities. And the thickness of the line is proportional to the number of trials that directly compared those 2 modalities. So for this network plot, you can see that the most common medication that used was IV indomethacin, but the biggest comparison was IV indomethacin to standard IV ibuprofen. This slide is simply here to show you the numerous different dosing mechanisms that they found in these 68 trials. And this is how they presented their data in this study. They used sucrograph, which is what this is called. Sucra stands for surface under the cumulative ranking curve. Basically what it is the higher the sucra value, the higher likelihood that a therapy is in the top rank or one of the top ranks. In the boxes, you can compare the odds ratio of 2 treatments. An odds ratio of greater than 1 would suggest that the upper left treatment is associated with higher odds of having the outcome of interest versus a lower right treatment. If the odds ratio is less than 1, it's the opposite. So I'm going to point out a few numbers in this slide to help it make sense. So oral ibuprofen had the highest sucra score, meaning it is the highest ranking among all the modalities of PDA closure with regard to PDA closure. Although it's really not much different than high dose IV ibuprofen or acetaminophen oral. Sucra scores were 0.89, 0.84, and 0.82 respectively. So really not much difference. This is the odds ratio comparing high dose oral ibuprofen and acetaminophen. It is 1.23 with a 95% credible interval of 0.62 to 2.48, thus not statistically significant. But when you compare high dose oral ibuprofen and acetaminophen, when you compare oral ibuprofen with IV indomethacin, you see the high dose oral ibuprofen performs better, and the odds ratio is statistically significant. So this is the exact same idea with regard to the outcome of needing repeat pharmacotherapy. The modality that had the highest sucra score overall was the high dose IV ibuprofen, but it was not much different from oral acetaminophen, 0.83 and 0.82 respectively. So they provided a slide like the previous one for every outcome and every adverse event that they looked at in the meta-analysis. And then they took all the modalities and outcomes and created this heat map. For each outcome, the number of studies, including the analysis, is in parentheses. For example, PDA closure of the 68 studies, 60 of the studies reported that outcome. So when you look at this heat map, you can see that oral high-dose ibuprofen was the most successful at closing the PDA, with IV ibuprofen and oral acetaminophen not being far behind. When you look at BPD, the outcomes of IV ibuprofen ranks as the worst, with oral acetaminophen ranking towards the top. But when you look at IVH, you can see that acetaminophen performs the worst. So the ultimate results of this, so this heat map is kind of fun to look at in more detail if you want to pull the study. But basically, the overall outcomes of this were that the overall rate of PDA closure was 67%. High dose oral ibuprofen was associated with significantly higher odds of PDA closure versus standard dose IV ibuprofen. High dose oral ibuprofen was associated with significantly higher odds of PDA closure than standard IV ibuprofen. And based on the ranking statistics, high dose oral ibuprofen ranked as the best option for PDA closure and to prevent surgical ligation. And there was no significant difference in the odds of mortality, NEC, IVH with the use of placebo or no treatment compared with any of the other treatment modalities. So in the end, I kind of take from this that all the modalities seem to work relatively equally well, with acetaminophen maybe having fewer side effects than ibuprofen or indomethacin. But what if we just leave the PDA alone? What if we don't do anything? And that's what this PDA Tolerate trial did that was published in 2019. So this was a trial that included 202 infants, less than 28 weeks gestation, on greater than minimal respiratory support with a large to moderate PDA enrolled between 6 and 14 days. The neonates were randomized to either early routine treatment with indomethacin, ibuprofen, or acetaminophen, with indomethacin backup if no closure. And the other arm was conservative treatment, and those infants received no pharmacologic treatment to close a PDA. The decision as to what medication to use was left up to the providers in the hospital in which the patient was in, as they felt in the study that there was no difference in the efficacy of indomethacin, ibuprofen, or acetaminophen. The conclusions of this trial were that there was no difference between the groups with regard to primary outcome of ligation or presence of PDA at discharge. There was no significant difference in NEC, BPD, death, or weekly need for respiratory support. And for infants greater than or equal to 26 weeks who received early therapy, it actually took them longer to reach full enteral feedings and had higher incidence of cons and death. So maybe we should just leave the PDA alone, is what this trial would suggest. But then what about the Piccolo device? This may actually change the way that we manage PDAs in the future. In 2020, this was published as a single-arm prospective multi-center non-randomized study. They had 200 patients greater than or equal to 700 grams enrolled at 9 centers. Only 100 of the 200 were less than 2 kilos. They looked at the primary effectiveness of the rate of PDA closure at six-month follow-up, and then they looked at safety endpoints of rate of major complications. This study was able to show a 95.5% overall success with actually placing the device. And it was 99% effective in patients less than 2 kilos. Of the patients that were implanted, 99.4% had PDA closure still at 6 months. 4 patients experienced a major complication. And 5 patients less than 2 kilos experienced worsening tricuspid regurgitation after procedure. And this whole study ultimately led to the FDA approval of this device for infants less than or equal to 700 grams and greater than 3 days of age. So in 2021, so a year later, a meta-analysis was published in the Journal of Pediatrics regarding this topic. And they were investigating the technical success and safety of the percutaneous PDA closure in infants less than or equal to 1.5 kilos. They included 373 infants less than or equal to 1.5 kilograms, and technical success occurred in 96% of the percutaneous procedures. Although adverse event rate was 27%, or roughly 1 in 4 patients. A major adverse event occurred in 8% of the patients. Now, an adverse event could be bleeding or something of that nature and not a major event, but they were reported. There was a 2% death rate related to the procedure, with 4 out of the 5 patients being less than 0.8 kilograms. And overall, what they saw was that the weighted intervention decreased as time went through on this study, and the procedural success also decreased or increased over this time, and that the complications decreased over time. So when I talk to experts about this, who do this on a routine basis, that was kind of their takeaway, is that you build the program of closing PDAs via a transcatheter approach in a stepwise fashion. You don't just decide one day that this is the practice your hospital is going to take and you begin with a 900-gram infant. You start with the bigger babies and you work your way down to a comfort level. So we are starting to do this at UVA over the last 3 years. And here's one case we had referred to us. This was a 7-week-old baby born at 25 weeks gestation with a birth weight of 830 grams. The baby's weight at referral was 1.6 kilograms. The neonate's respiratory course had consisted of early surfactant, high-frequency ventilation with a transition to SIMV after a course of DART therapy. The FiO2 of the infant at transfer was 35%. The neonate had an echo with a large PDA and moderate left atrial enlargement, suggesting stress on the heart. And the history of medical therapies to close the PDA had been unsuccessful, and the infant was on Lasix at the time of transfer. So this is the neonate's X-ray on admission. It shows cardiomegaly and severe pulmonary edema. The patient went to the cath lab 2 days after transfer and had a piccolo device, which you can see with the arrow, and returned to the NICU without any complications. This is a comparison of the admission X-ray and the post-cath day 1. We see reduction in the cardiac silhouette and decreased pulmonary edema. And the patient was transferred back to the referral hospital on post-cath day number 2. At UVA, we're just beginning this journey. We have a multidisciplinary group that reviews the data for the patients referred, either internally or externally, for potential PDA closure. We've proceeded on this journey for the last 2 to 3 years and are performing the procedure on smaller and smaller babies, with 1.5 kilos being the smallest we've done to date. The group consists of the interventional cardiologist, the cardiologist who specializes in pulmonary hypertension, myself, and a pulmonologist. So this is where we are in 2022. We have so many options once a patient is diagnosed with a PDA, and there's no real consensus on the right thing to do, despite studying the PDA since the 1970s. So in conclusion, I asked you to remember the questions that I posed to you at the very beginning when people started thinking about the PDA in the 1950s. As you can see, we still have very similar questions today in 2022. With the new question of, does the ability to perform catheter closure in smaller babies change the decision tree? I think potentially we could start seeing some changes in the years to come as more evidence and more studies are published on this outcomes. So stay tuned for future years when I may be able to give you an update on that. Thank you, and I am available for any questions.
Thank you very much.
Do I stop sharing?
Yeah, you can stop sharing. That's fine. And let's see if anybody had any questions. The chat is open, as is the Q&A. If you want to raise your hand, because we have a smaller group, you can raise your hand and I can give permission for you to talk if we have any questions.
And I'm glad to see it's World Neck Awareness Day.
Yes. So perfect timing for that. All right. I am not seeing. We have a very thorough discussion for a comment.
I am fine with no questions. I'm happy to answer them, but I'm also fine with no questions.
I think it looks like, sounds like you were very thorough, so there is no questions. So,
all right. Well, thank you everyone for having me.
Thank you very much and have a great afternoon.
Thank you.
All right.
Bye-bye.